try to address some of the current needs. The second thing that can happen is some collaboration between teacher, principal, special education teacher, and parent. Because I think sometimes what happens is parents are trying on one hand to cope with one certain behavior and target one certain behavior, and teachers are trying to target another behavior. So having a consistent sort of behavior intervention strategy, if you will, often really works to help the student. It also helps kids like Bobby, who already feel like they're failing, to know that the adults in their lives are doing things consistently and that they're listening to him. And a lot of times that's something that kids don't feel that adults do. Again, from a Catholic Board perspective, the next step that could be taken possibly is we have a board-level collaborative team which consists of behavior consultants, psychoeducational consultants, speech-language pathologists, social workers, and special education resource teachers. Those are consultants who work, again, with the in-school team to problem solve, to help identify issues, to put plans into place, and to make recommendations about how to help that particular student. There's generally a link to learning, especially with feelings of failure. We generally know that kids who are feeling not good about their schoolwork generally don't feel good in life in general. So the two often cause issues of self-esteem, issues of frustration, and poor performance, loss of sleep, loss of appetite. So again, having teachers and parents really sort of on board together to help each other understand what is happening for that particular student. The big piece for me was around Bobby's ADHD. It's a medical diagnosis, and teachers are often inexperienced in dealing with students with ADHD from a medical perspective. So one of the things that's often very helpful is for, again, teachers and parents to collaborate in asking a physician or asking a psychiatrist who might be involved, asking a doctor who might be involved, what does ADHD mean for Bobby at his particular age? Because ADHD looks very different in a student who's 6, looks very different in a student who's 9, and very different in a student who's 12 and 15, and so on and so forth. So oftentimes it's very helpful to have physicians involved, or even physicians to make recommendations to the school about things that would be very helpful. Most schools have a variety of level of services and support staff to help kids. I believe that from the public board perspective, elementary schools and senior public schools may have different services again, and high school may have different services, but at every different school there are access to guidance counselors, to child and youth workers, to special education staff, as well as in the high schools. The provincial government in the last number of years has set up what's called a student success department, and has given teachers specialized training on how to help our most at-risk kids. So there are tons of things that can be done at the school level before we make recommendations to our community friends. So again, it's about schools, parents, and community all working together.
So back to looking at what supports are available in the community. One of the things that I haven't touched upon is we put up there the CMHA 24/7 crisis services. And this service is a crisis line service, and a lot of the schools, the high schools, on the back of the student ID card, they have the number for the crisis line services. And I know that the crisis line also advertises within the schools by putting posters in places that kids hang out, like the washrooms, that there is a crisis line available. And it truly is a crisis line where if somebody is in distress, they can contact the number and speak to somebody on a 24/7 basis. Once again, I've put brochures at the back for people to pick up if you'd like it, and it does have the crisis line number outlined on there.
Can you just remind us what CMHA stands for?
Sorry, CMHA is the Canadian Mental Health Association. And one of the differences between, you see, Lutherwood Mobile Crisis Services and CMHA Crisis Services. The CMHA Crisis Services offer a crisis line, whereas the Lutherwood Mobile Crisis Service is not set up to be a crisis line. You can access the mobile crisis service offered by Lutherwood through the front door. And once again, those brochures are at the back.
Okay. So let's move on then to what we would consider an urgent or a crisis. And I'm going to just remind you again that when we talked about this, we talked about Susie, and Susie had a diagnosis of depression, had been on her medication, but it doesn't appear to be working, family history of suicide, breakup with her boyfriend, and an issue with regards to hoarding her pills. So when we look again around the possible motives, certainly Susie was starting to feel very alone and for whatever reason different. She was frustrated and certainly was sensitive to the things that were going around, feeling misunderstood and probably judged, had been exposed to suicide and really was looking at that issue of escape from the pain around probably the family history of depression, her own diagnosis of depression, and certainly now we have that business of an event. Susie had a recent breakup by her boyfriend. The red flags then certainly included that, certainly again included depression, the family history of suicide, and the lack of interest in previously enjoyed activities. And again, that I didn't have on there, and I should have, was the piece around hoarding her medications. So now we've upped the ante and we have kind of more of those red flags that are kind of flashing in front of our face. So again, I'm going to invite Sue and Kathy to come back and talk about is there something different that might happen if we kind of reach that a different level when it comes to the school board and the front door.
Once again, you're certainly able to access the services at front door and the mobile crisis team. In this situation, though, the services may assist you in determining, is it, due to sort of the heightened nature of some of the motives, and along with the event occurring, it might be time to look at, is it time to create a plan so that we can address your concerns if we're looking at, a triggering event that might have pushed this into a more serious nature. Our services could also help the family get to the hospital if that's needed.
Well, yeah, and I also think a big part of what Lutherwood and what Lutherwood Services does is start to look at what a safety plan might look like. And at one end of the spectrum certainly would be helping a youth and a family move towards the hospital if that's what it needed to go to, or to back to the family doctor or to the clinician to kind of work through what's the issue that's happening at the moment. Stories are always helpful, I find. I can tell you when I first came to Benjamin Road, I work at the residential services at Benjamin Road, and we had a young lady who was, again, highly suicidal, and what she would do is she would run out onto the road in front of Lutherwood, and Lutherwood is on Benjamin Road, which is kind of right adjacent to St. Jacobs at the edge of whatever. It's a pretty busy road these days. I came in and they had brought her back in, and we had what we call a safe room. So she was in the safe room. And I had many staff coming to me and saying, we've got to get her to the hospital. How are we going to get her to the hospital? What's going on? And you have to realize that with youth, there are times when red flags push a youth up to a peak. If you can deal with what's happening at the peak and you can surround that youth with a safe place and safe people, and to take away some of that pain, it can come back down. Doesn't mean it might not go back up. It might go up higher, it might go up lower, depending on the services we're able to get. But at that very moment, if we can bring it back down and start to work with the youth and the family, that's a place that front door can help. And it's one that goes up and it stays up. That's the difficult. So what I run around the corner, there are many people coming to me and saying, get this youth in the hospital. And I looked to the clinician, I said to the clinician, what do you want to do? And she said, I want to be able to take this, take the opportunity to bring in mom and to bring in this youth and to do some safety planning and help mom hear what this young lady is saying. And it was the most therapeutic thing that happened with that young lady because we were able to utilize that moment and certainly come up with some really concrete safety plans. And I think that that's one of the things that certainly the front door in Motherwood is very, very good at, as is the community, don't get me wrong, around making some really good safety plans for these youth. Kathy, I'm wondering if there's anything different from the school board's perspective if they ended up with the youth.
Certainly, I would hope that if there is a youth at a school that has disclosed that he or she has ingested any type of medication, that the ambulance would be called. I believe that's protocol. I believe that's common sense. I would like to think that it would happen all the time. Immediately after that emergency call would be a phone call to a parent to let the parent know that that action has been taken and the necessary steps from there. Different from the community, and I think as a school acting in parentis locus, we are not the students' parents. So we would work with parents to work on what our next steps would be, hence unless it was a crisis where a student had ingested something or had made a deliberate, intentional suicidal gesture or act in our buildings. If we step back to the second scenario of Susie before we know that she has ingested medication, I think what would happen from a Catholic school board perspective, we for the last 25 years have been very proud to own a protocol about suicide, depression, and self-harm intervention. There are social workers in our board who are specifically trained and who are called upon to respond to the immediate needs of students who are feeling unsafe or who let us know through their statements or through their drawings or through their journal entries that they're not safe. And with parents' permission, a social worker can be involved in a variety of ways, one of which includes an immediate assessment. So, the social workers are deployed to the schools and are meeting with students around and doing essentially a miniature triage to sort of exactly what Kathy had said, sort of understand what some of the issues are, understand what is going on for this student. Are there things we could put into place that minimize risk? Or has the risk peaked and now we need to have a more intrusive plan? Sometimes that works, sometimes that doesn't work for kids. Sometimes students are in places where they're just not able to talk about that. So other safety issues are put into place. Parents are always contacted. The law is very clear that confidentiality rules change in an emergency situation. So even our students who are 18 who tell us that they don't want their parents being contacted, when we are concerned about their immediate safety or the safety of other students, we have the right and the responsibility, as far as we're concerned, to make sure that student is safe and call upon somebody who will help him or her. I know that my colleagues in the public board also, their guidance counselors are trained in mental health and suicide assessments as well, and work as far as I know in a very similar fashion. But there are folks in all of our schools that are trained that can help understand what's happening with students and help get them through the next steps.
And finally, in the emergency, and you jumped ahead a little bit here, Kath. This was the non-injured, but that's okay. You talked about the emergency one as well from the school board perspective. That I'll just remind you then that this was about Susie again. But at this point, Susie had one scenario might be that she has the pills in her hands and she's insisting on taking them, or she has come to her mother and said, I've actually already taking these medications. And really, when it becomes an emergency, we do have emergency facilities. Pauline's going to talk a little bit more about those in our community, and those are really the ones that you need to use at that moment. So, in essence, we've crossed out the front door. That's not a place that you would go in emergency, mobile crisis. And I've crossed out the schools, but as Kathy said, it would certainly result in an immediate response by the team there at the school.
You know, as I read the scenario about Susie, I can well imagine that a parent would be quite panicked around both of those issues. Scenario number one, where she is handing over the pills, or has the pills, and is indicating that she's going to take them and insisting on doing that. And scenario number two, where she has. I think both scenarios are going to create huge anxiety, huge panic, huge feelings of helplessness, and not quite knowing what you're going to do at that time. When I read that scenario, though, my thought was also one of being quite hopeful, and that thank goodness that this young girl, Susie, has enough of a relationship and also enough of a life pull that she goes to her mom and tells her mom either she wants to take and is insisting on it, or she has taken them. That's an opportunity, and bless the mom that there has to be some kind of relationship, and bless Susie for actually being able to come forth and want to live. Otherwise, we wouldn't have that opportunity to talk to Susie at that time. So what happens in both of those scenarios? Number one, for the mom, I think if there's any possibility that one can negotiate with Susie around handing over. So we talked about reducing access or eliminating access to a method of harming oneself or suicide. If there's enough of a relationship, then I think in scenario one, the mom would want to ask Susie to hand over those pills so that they're not accessible. If that's not an option, and Susie's not prepared to negotiate with that, then I think we're into calling 911 and ambulance. And when you call 911, you usually will get ambulance and police who will show up at the same time, sometimes even the fire department. So using hospital 911 services like that is one of the most intrusive things that we do, both from a mental health point of view and from a physical point of view. Even some of the elderly, I don't call the ambulance, my neighbors will find out, right? So it's intrusive, and it feels uncomfortable for all family members, and even for the young person. But if we can't negotiate a kind of a mini safe plan with Susie, then we need to access that service. And the same, if in case two, where Susie has taken the medications, she's saying she's taken them. One may not be able to identify what she's taken, how much she's taken, how serious that is. So at that point, I think you're definitely contacting the ambulance to come and support. If you're able in scenario one to convince Susie to hand over, you may be able to accompany Susie voluntarily. She may be willing to go to the hospital. When you enter the emergency department, much like anyone with a medical concern as well, you enter those sliding doors, and the first thing you have to do is put your name on the clipboard, and then you may wait, or your name will be called very quickly, and you will see the triage nurse. A triage nurse is a medical nurse. She'll look at finding out if there's any medical concerns, and then do a really mini mental status, or just a quick questions around the mental health concerns that are there at that point. So that nurse will assess and triage. My story around triage, I remember sitting there with my father at one point, and he goes, "Pauline, what's triaging?" And it's like, we use a lot of medical terminology that for a lot of people doesn't make a lot of sense. But triage is looking at what is, how serious is this, and how soon do we need to bring this person in? And when you're sitting there in the waiting area, you can't really tell why this person got to go in before I did, and that can be very frustrating. And I can only reassure you that, one, they've triaged as best as possible as to their urgency, and two, that if you do have ongoing concerns, you need to go back to that triage nurse if you are in the waiting area. Once triage does their assessment, you'll be brought back to, there is a mini mental health area, and it's adult, children, adolescents that would be there. It's not a huge area. They are looking at renovating so that we can accommodate that to be a bit different. Then typically, either you can ask for the emergency crisis team, earlier referred to as the crisis clinic. It's now changed its name to the emergency crisis team. And one of the staff, and it's nurses that staff the emergency crisis team, will come and spend some time talking with the identified individual, whether that is the adolescent, and certainly try and involve the family, if in fact the family, the young person is wanting that. And I would definitely assume that in this case being 16, that the family would be involved. So that's the one where you get through to in an emergency service if you're walking through the door. If the ambulance has been called, then they're coming through that back ambulance entranceway. And triage still, but are being accompanied by the ambulance and will be triaged by the triage nurse at the same time. Because of the concern of having taken medication, the first thing they're going to do is medically make sure this individual is okay. And I realize, we're talking about someone who's quite distressed, but the priority is going to be ensure that physically and medically we stabilize the young person and make sure that they're safe before they even address the mental health concerns. And I know that sometimes feels not quite the order it should be, but because they won't know exactly what she has taken and what the severity of that is, if there's any other medical concerns that are happening at the same time. So medically they will clear, and then they will also then access the emergency crisis team. As family, you can also, if you enter the emergency department, you can request that the emergency crisis team be involved. There is a psychiatrist on call 24/7. He is on call to the emergency crisis team and to the emergency department. And he or she will come in and do an assessment if that is felt deemed necessary. If admission post-assessment is recommended, it is a psychiatrist who arranges admission to the hospital. The inpatient services, we do have a child and adolescent inpatient service. I didn't move forward. Oh. Yep. So I've looked at triage, medical intervention if needed. If an admission is arranged, we have an 8-bed child and adolescent inpatient unit, which currently is on the 9th floor, and renovations are underway to actually have a much more respectful, warm environment that will be on the first floor, and hopefully those renovations will be completed in the early spring. It's a short stay. Most acute hospitals, it's a short stay. 5 days is the average length of stay. Does that mean that 5 days you're discharged? No, it means that some individuals may stay for 2 weeks, some individuals may stay overnight. But on the average, the ministry will ask that it's a 5-day stay, and it really is to stabilize. They have a multidisciplinary team. They have school teacher who can support continuing academics, social work, psychology, as well as psychiatry, and youth workers. So they have a number of different people who work on the inpatient unit. So we've talked about front door, we've talked about Lucid with mobile crisis, Canadian Mental Health Association's 24/7 crisis service, what schools play, and now I just want to touch a little bit on GRH outpatient services. But maybe before I do that, one of the things with Susie, she's on medication. Someone's prescribing medication. At this point, I'm going to assume it would be a family physician, and depending on family physicians, depending on the relationship that anyone might have, it's a great resource, and one who can actually be the one to ensure that all medical and mental health services are being organized for an individual to be the primary care person to make that happen. Number of programs at the Grand River Hospital's outpatient services, and I've left a brochure at the back, which does identify for children and adolescents. You can call the outpatient department, the central intake number, at 749-4310. It's in the brochure. And you'll be given the option of 1 and 2. 2, I believe, takes you to the intake worker for the child and adolescent services in the outpatient department. And they provide consultation, they'll provide short-term support, There's a program called the Young Adult Program, and then most of them are outlined in the brochure. But you can, family and an individual can refer themselves to the child and adolescent outpatient services. Adults cannot, but at this point, we are still able to support accepting calls from individuals themselves who can self-refer and or family can refer on behalf. So hopefully, if you're not quite sure, that is another avenue to go through. If that's something you can access front door or something. But there are a lot of programs in there outlined in the brochure. One of the things I want to talk about just briefly, because I do have a DVD at the back, we have a family advisory group called Families for Awareness, Change and Education within mental health services. And bless them, and certainly Tina is in our audience today and sits on our family advisory group. Going back quite a few years ago, from the family education series, a number of family members, when we went to do a similar talk to what I'm doing here around the wonderful services that Grand River Hospital offers in mental health, I'd say about 7 years ago, we were not met with warm fuzzies by these individuals who were quite frustrated with feeling that they could not access services in a timely way at the hospital. And out of that came this family advisory group, which does advise our program around how to be more family-centered and how to support family. And so there is a DVD here, which please take a copy. It's family members talking to you, other family members, with hope of moving forward as all of you go through your journey of recovery when someone has a mental health issue. Limitations. I think we've talked about limitations. Confidentiality probably always comes up as one of the biggies in regards to the Privacy Act, et cetera, and how much information can you receive from healthcare providers or anyone in regards to your loved one. So it's an ongoing issue. There were positive things around the Privacy Act and also some negative things, but families can always provide information, and yeah, it is one of those challenges. Systems, yeah, we need to work better together, we need to work closer together. That's why it's always wonderful to come and be with a group of people who represent other agencies, that we are working together to support individuals. And gaps in our service, one of the biggest gaps we have is the 16 to 18-year-old. 16 is not an adult, but for a number of services it's considered an adult. The hospital will view 19 and over as adult, and 18 and under is child and adolescent. But CMHA services services people 16 and over. And so then the age 16 to 18 are the adult, are the young people. It's definitely, we need to support anyone no matter how old they are, but that definitely is a challenge. And there's lots of other, I'm sure you've got your own ideas on what are some of the limitations in accessing service, and that goes back to that roundabout. What we do hope at some point as we work towards improving the system is that we have a comprehensive continuum, that we start to ensure that services are there when you need them, and that the levels of need, like your first line, your intensive, or your specialized, so that someone who has ADHD might be able to get specific treatment that supports someone with attention deficit, that we're streamlined, fewer points of entry, that one point of entry or no door is the wrong door, and shared services to respond to those individuals who access multiple services, and importantly that the individual is at the center of their care. Recovery is a word that is in our community shared by a number of agencies, and it really means moving forward and supporting individuals with self-determination, without setbacks, moving forward, involving them in having self-control over their life, that they're not their illness. And I think most important, and what I talked about with Susie, was hope. That is really the foundation of everything that all of us do, and you as family members, to support someone in their journey of recovery with hope and with being hopeful about your futures with your family member. So I'm actually going to turn it over to Dana, who will kind of finish off a little bit.
indeed it is a really complex area, as I know you all know, and supporting a teen, a youth that is in crisis. It involves many levels of support and intervention. Certainly this mental health series is one of those areas of support in terms of bringing certain information, education, reducing the stigma. Those are all areas that are important in kind of moving towards access of service. As was stated earlier, we want to be able to kind of reduce the stigma, begin to talk about it, so that the youth is able to move towards, and their families, to move towards accessing the services. It's not a straightforward path, but we hope that by narrowing it down to 3 levels of entry, that might be helpful for you to try and navigate the system. The other thing that's happening in the community in terms of affecting some level of change and hope and well-being in our community for our youth is talking about the prevention side. And so I just wanted to highlight that together with programs like this program for mental health services for youth and many other services through the school board, through local agencies, private agencies, and places like the Suicide Prevention Council, these are all kind of in the background, working continuously to bring about education, awareness, and levels of skill that help both families and youth attain their stability and well-being before we get to that crisis. So we too, as a representative, as one of the representatives of the Suicide Prevention Council, wanted to let you know that there is an army of people in the background working tirelessly to develop those links, to develop that educational material to provide throughout the city, our cities. You know, I've been involved in this field for a long time, a little over 16 years, and I can tell you that the climate is so different today than it was even 10 years ago. If you walk into any high school and you talk to youth about suicide, they know its complexities. They know that it's as a result of a distressful situation, mental illness. They understand that it is something that needs to be paid attention to, that something that can also be helped and assessed. 10 years ago, I don't believe that our youth were able to talk about the issue of suicide. We're not all the way there yet, but we have made great strides. And it is through these partnerships with community programs, and if I may say, the Suicide Prevention Council, who has worked tirelessly to keep knocking on the doors of those who can affect change to help that.